Good afternoon, everyone. I'm going to talk about the ADRENAL trial today. Adjunctive glucocorticoid therapy in patients with septic shock. The lead investigators were B. Venkatesh and others. They were part of the NZICS, the Australia New Zealand Intensive Care Society Clinical Trials Group. A bit of background before we start the trial. So we know the normal cortisol levels, they vary between 5 to 25 mics per deciliter. And we got this diurnal variation of cortisol. The levels are highest in the morning, and then they decline throughout the day. But whenever there are states of physiological stress on the body, sepsis, infection, this diurnal variation is lost, and the steroid levels, they go as high to 40 to 50 mics per deciliter. Now, it has been seen that during these stressful periods, the cortisol production can be suboptimal, so we have a state of relative adrenal insufficiency. Whether serum cortisol, whether exogenous administration of steroids in these states of functional insufficiency can help improve the mortality. Now, this topic has been the focus of extensive debate and study for the last 5 decades, I would say. I'm not going to go through all the previous trials. I'll just try to highlight the landmark studies in this region. The first one was done by ADRENAL. It was a French multi-center trial, came out in 2002, which said that there is a benefit with steroids, 28-day mortality benefit. And then the Corticus study was pan-European multi-center study, came out in 2008. They said there is no benefit, but both of these trials did say that there are some secondary improvements in the patient outcome, early discharge from ITU, earlier resolution of shock, something like that. Then came the Approaches trial back in 2018, which was again done by ADRENAL, the original French investigator, where they said that there is a 90-day mortality benefit in patients with septic shock who receive steroids. The current surviving sepsis guidelines, however, they say that we should use steroids only if we're not able to maintain adequate blood pressure after adequate fluid resuscitation and the use of vasopressors. That's a weak evidence as of now. So there's quite variability in the use of steroids in septic shock worldwide. To address these concerns, the ADRENAL trial was done. So talking of the design of this trial, it was an international pragmatic double-blind parallel group randomized controlled trial of patients who had septic shock and who were undergoing mechanical ventilation. So the trial investigators, they took a sample size of about 3,800 patients, which would have provided them with a 90% power to detect a 5% risk reduction from assuming a baseline mortality of 33%. And that also included a false positive rate of up to 5% and about 1% loss to follow-up and or withdrawal. The setting, this trial was done in over 69 medical and surgical ICUs. Most of the sites were in Australia and New Zealand, but UK had 12 sites, 3 in Saudi Arabia, 1 in Denmark. It was done over a period of 5 years from 2013 to 2017. The inclusion criteria, if you look at these criteria, they were quite robust. Adults who were undergoing mechanical ventilation with documented or strong suspicion of infection and who fulfilled 2 or more criteria of SIRS, number 1. Number 2, they were on continuous vasopressors to maintain a systolic pressure more than 90 or mean pressure more than 60. And number 3, they were on vasopressors for at least 4 hours, and that was present at the time of randomization. So, I mean, these criteria are quite robust. And coming to the exclusion criteria, patients who were to receive or who had received steroids for any other indication apart from septic shock, who received etomidate during induction, or who were sort of end of life and who were expected to die in the next 3 months from some other pre-existing disease, who has some DNR in place, or who met all the inclusion criteria for more than 24 hours. So these patients were not included in this trial. So the randomization was stratified according to the participating center and according to the type of admission, medical versus surgical. The blinding was ensured by a supply of hydrocortisone and placebo in identical masked vials. The trial regimen, so they made it to a concentration of 1 milligrams per ml. The volume was set at 200 mLs, which was given as a continuous infusion over 24 hours for a maximum period of 7 days or until ICU discharge or death, whatever occurred first. The patients, treating clinicians, and the trial personnel, they were unaware of the trial group assignments in the sequence. Every other aspect of the patient care was at the discretion of the treating clinician. Outcomes. The primary outcome was 90-day mortality from any cause. There had lots of secondary outcomes: 28-day mortality, time to resolution of shock, reoccurrence of shock, length of ITU and hospital stay, duration of mechanical ventilation, the frequency and duration of treatment with renal replacement therapy, incidence of new onset bacteremia or fungemia between day 2 and day 14 after randomization, and the requirement of blood transfusion. The primary outcome, which was mortality at 90 days, was also examined in 6 pre-specified subgroups. That was type of admission, number 1. Number 2, the dose of catecholamine. So they divided into 2 doses, less than 15 mics per minute or more than 15 mics per minute. The primary side of sepsis, pulmonary versus extrapulmonary, gender, male versus female, and Apache scores, less than 25 or more than 25. The last was the duration of shock according to 4 intervals of 6 hours each, between 0 to 24 hours before randomization, less than 6 to 12, 12 to 18 hours, or 18 to 24 hours. So these were the different subgroups. So this chart basically has sort of compared the baseline characteristics of the patients in both the groups. So I'm not going to go through each and every aspect, but just to give you a fair idea, most of the patients were aged 60 years and above. Predominantly they were male, 60%. Medical admissions were about 70%, 30% were surgical admissions. The mean Apache score was about 24, and they've said that scores of more than 25 means that the patient's mortality is 50% or above, or they're more sick. So their scores are about 24, so below that number. About the physiological variables, I'm just going to go through the lactates levels. So the units used are milligrams per deciliter here, so that comes out to about 4 millimoles. So the highest lactates were in the range of 4 plus minus 2. The PF ratios were in the range of 160 plus minus 90. So if we go by the definition of ARDS, they were like moderate to severely sick from that point of view. The most common site of infection was the lungs. And the one important thing I'd like to highlight here is time from shock onset to randomization. So if you look at this period, it's 20 plus minus 91 hours. So that's almost 24 hours. So these patients on an average about 24 hours, they had the shock onset and then they were randomized after that. So they did not receive steroids till about 24 hours. According to subgroup type, I'm gonna stress out on this bit, the catecholamine dose more than 15 mics per minute, which means patients who were more sick. There were about 53% of these patients. And talking of the Apache score of more than 25, as I said, the more sick ones, there were about 45% of patients who had scoring of more than 25. Coming to the results, so they took about 3,800 patients from different ITUs whom they randomized. Out of them, 3,658 patients were actually included in the primary outcome, 1,832 patients in the steroid group, and 1,826 in the placebo group. The median time from randomization to commencement of the trial regimen was about 0.8 hours in both the groups. There was no significant difference in the cumulative duration of trial regimen. It was about 5.1 days in the steroid groups and 5.6 days in the placebo group, with significant p-value. If we talk of the breakdown, admission type breakdown, so these are things I've discussed already. Medical admissions were about 68%, surgical 32%. So almost 100% of the patients were on some sort of mechanical ventilation, inotropes and vasopressors. They were receiving antimicrobials. So the primary outcome, death in 90 days, steroid groups, about 27.9% patients had died, and the placebo group had 28.8%. The odds ratio was less than 1, was 0.95. P-value was not significant. So out of these patients, 7.4% of the patients in the steroid group and 8.8% in the placebo group, they did receive some open label steroids too. But even after doing a post hoc analysis of the primary outcome where they excluded these patients, there was still no difference in mortality. There was still odds ratio was less than 1 and p-value was not significant. So this is the odds ratio of mortality at 90 days across the 6 subgroups which I discussed. So it's a forest plot. I'm not going to go through each and every value, but just to highlight things here, as we can see that the 95% confidence intervals of almost all the variables, they're crossing the vertical line of no effect, which means they were not statistically significant. However, if we look at the catecholamine dose, the subgroup which had higher requirements, 15 mics per minute, they probably had some benefit with steroids, although it was not statistically significant, number one. Number two, if you look at the Apache score, the patients who were less sick, score of less than 25, they had probably some benefit effect from the steroid arm, but not again significant statistically. And if you look at the time from shock onset to randomization, the group who were randomized in the window of 6 to 12 hours, they did better with the steroids. Again, not significant statistically, but yeah, these were probably the only, you know, outcomes from these 90-day mortality in the 6 subgroups. Not significant, but they were heading in one direction. If we talk of the secondary outcomes, there were some significant differences. The time to shock reversal, it was 3 days in the steroid group versus 4 days in the placebo group. Significant p-value, hazard ratio of more than 1. The time to cessation of initial ventilation was 6 days in the steroids group versus 7 days in the placebo group. Again, significant. Median time to discharge from ITU was 10 days in steroids versus 12 days in placebo group. Significant. Use of blood transfusion, it was less in steroids group, surprisingly, which was probably a hypothesis generating thing, but these were the positive findings in the secondary outcomes. The rest of the the outcomes were more or less the same. There was no difference in mortality, recurrence of shock, number of days alive and out of the ITU in hospital. They were same in both the groups. Rate of renal replacement therapy, new onset sepsis, bacteremia and fungemia was in fact same in both the groups, steroids and placebo. If you talk of the adverse events, they were significantly higher in the steroid group, about 21 events in the steroid group versus 6 in the placebo group, so more than 3 times. The most common being high blood sugars, poor glycemic control, which is expected from the steroid arm, hyponatremia, encephalopathy, delirium, hypertension. Coming to the serious adverse events, so these events they defined as those events which were sort of life-threatening or sort of prolong the patient's stay in ITU. So there were 4 events in the steroid arm, 2 of myopathy, 1 ischemic bowel, 1 circulatory shock, 2 in the placebo group, 1 bleeding and 1 abdominal wall dehiscence. So if you talk of the strengths of this trial, number one being it was an international double-blind parallel group randomized controlled trial, which sort of increases the validity of the results attained. The patient population, the numbers they took were quite large, 3,800 patients. In fact, if you look at the previous trials, which I mentioned in the beginning, the ANAN trial had about 300, the Corticus had 500, the Approaches trial, which came out recently, had about 1,241 patients. The ADRENAL trial had about 3,800 patients in total, so the number of patients were high in this trial. Even before the trial was completed, the trial protocol and the statistical analysis plan was published to help reduce the bias. They even examined the primary outcome in 6 pre-specified subgroups to ensure that no one subgroup would benefit more from the steroid therapy. The baseline characteristics were sort of comparable in both the steroid arm and the placebo arm. And the results, they were verified in 5 different hospital systems, so which sort of increases the external validity of this trial. If I talk of the limitations, the weakness of this study, of the trial, I would say that the patients who received etomidate, they were excluded from the study. However, having said that, many providers still may be using etomidate in RSI in septic patients, which they do. They didn't collect the data on all the secondary infections. They just said incidence of new bacteremia and fungemia. That's it. The appropriateness of the antibiotic therapy given was not. There was not a formal, sort of understanding about that. The rate of recurrent ventilation was used as a surrogate for myopathy, but the long-term neuromuscular weakness was not assessed, and the amount of fluid used in both the arms was not clear. It was treating clinician based basically, so we were not sure how much fluids the steroid arm received or the placebo arm received. So these are some sort of the limitations of this trial. So outside the steroids, the rest of the management of the patients was at the discretion of the treating clinician, which although they did follow the evidence-based management guidelines for sepsis, but it was still at their discretion. So that could lead to some variations. So having said that, is it the, as per the author's conclusion, is it the end of road for steroids in sepsis or septic shock? We don't know. I don't know. So the authors have concluded at the end of the study that among patients with septic shock undergoing mechanical ventilation, a continuous infusion of hydrocortisone did not result in a lower 90-day mortality as compared to placebo. but there were some improved secondary outcomes, including shock reversal was earlier in the steroid group, the ventilator-free days, length of stay in ITU, and probably fewer blood transfusions, though they've said that could be hypothesis generating thing. Yeah, but we could say that there were some positive secondary outcomes in the steroid arm. Would or should it lead to a change of practice? Now, we're not sure, but we do know one thing for sure, that steroids are still reserved for patients with resistant shock. Now, what is a resistant shock? Maybe when you're exceeding a certain dose of noradrenaline, or you have to add a second vasopressor to that, or maybe when you feel that your patient is persistently vasoplegic and you're not able to get on top of the blood pressure despite adequate amount of filling or squeeze. Probably is that the point when you start steroids. We did see that there was a modest benefit in some secondary outcomes in this trial. Earlier resolution of shock, earlier discharge from ITU. So should we give steroids even to less sick individuals for those secondary outcome benefits? We don't know. The mortality is still not unchanged as compared to previous trials, and the benefits are marginal. So and these trials were done over different countries over the world. So there's some heterogeneity in international practices. So obviously that would make one skeptical about the results of this trial. But we know for one thing that the maximum benefit is in patients who are sorry. So this line basically, if I go back to the odds ratio, so as we can see here, the benefit is more in patients who are having requirements of high catecholamine dose, more than 15 mics. There's some benefit or trend of benefit towards steroid arm, but not significant. And also patients who are less, whose Apache score is less than 25, they also seem to benefit. So higher dose of vasopressors and who are less sick in terms of Apache score, there's some benefit on these two groups of patients. That's the probably only thing which I could make out of this trial. Yeah. So yeah, the only signal from this trial is there's a trend towards mortality benefit in patients who are on high dose of vasopressors. That's the only takeaway I could take from this trial. Yeah. These are the references which I've used: an AN study and the Corticus trial, and the original trial itself. Thank you.
Thanks, Sam. So what do you think? Would steroids to people who are septic?
I would still reserve them for the sickest of patients in ITU. Who are where I have to start a second vasopressor. Probably I would still use in the same set of patients only. I wouldn't use them in less septic patients or whom I can manage with fluids and single vasopressor. Steroids itself, they are sort of immunosuppressant, so using them in critically ill patients, I would still not be very comfortable.
There are some whose steroids don't seem to make any difference, and what we don't know is how to effectively test who's got enough steroid hormone and who's missing out on it. And if you haven't got steroid hormone floating about, then yes, you are hypotensive. When we eventually learn how to figure out how to test which patients will benefit from it, then it might make life easier, but we haven't done that yet.
Yeah.
Has anybody else got any comments? There's anything in the chat? No, nothing in the chat.
What's everybody's arbitrary noradrenaline cutoff starting it?
Steroids are good because it gets cold.
Has anybody got a number?
Oh, really? Cutoff for what?
Starting steroids.
Yeah, someone's in septic shock and they're on noradrenaline. At what level do you consider starting steroids?
Oh, 0.5 to 1, isn't it? Well, it's escalating more than kind of a certain cut.
Especially if they're escalating and it doesn't make any difference.
Yeah.
those patients, I don't see what you've got to lose really.
I think in low doses you can increase mortality, which makes sense. So
Yeah.
if the dose is escalating, then you start it. I think once you reach 1, pretty much you should start it by then, isn't it?
And do any of the intensivists across UHL add in fludrocortisone? Because the Aprococious trial, which is the only one with a mortality benefit, use that. I don't know of anyone anywhere else that does, but
Great minds. I was just thinking that. Sorry.
Give them mifepristone instead.
yeah.
I think hydrocortisone itself has sufficient mineralocorticoid effect to sort of. And the other thing they've said is the dose they used in approach is 50 mics once a day, and the levels attained are very less. So I know there's a mortality benefit in approaches for sure. But then there have been studies which they've said the levels attained in blood with that 50 mics dose is very low, very less. So that shouldn't lead to a mortality benefit as such.
You got it the wrong way around. You can't. The basic science comes before the evidence, and the evidence at a randomised controlled trial level is that it has a benefit.
Mm-hmm.
I completely accept there's biological plausibility to it not working, but that's the evidence we've got. And it's just interesting. I've not seen any intensivists across any of the trusts in East Midlands that do use it.
We certainly don't at the Royal. We've just got hydrocortisone. I don't know that anybody's tried to use anything else. At least nobody else used it either. Cool.
Thank you for that.
Thank you.
Welcome everyone. Everybody here knows me. I don't know about the people at the Royal sitting there, but I'm one of the consultants from Glenfield. Hope to see you at some point during your training, working with us here. I'm going to talk in the next half an hour about congestive heart failure, which we can say it's not a single entity, which I was trying to explain. It's a complex clinical syndrome that's usually characterized by impaired ventricular performance, exercise intolerance, and high incidence of ventricular arrhythmias. And obviously all these patients will have a shortened life expectancy. So why does it happen? The etiology, as you can see, it can occur suddenly or develop gradually, but it's usually the final common pathway of a variety of primary cardiovascular disease entities. So it's not a primary pathology really, it's usually developed as a reason for other pathologies that affect the heart. The most common two are the coronary artery disease and hypertension, which are the major causes for development of heart failure in the elderly. Other common etiology include diabetes, which have a systemic effect on all different organs, valvular heart disease, especially valves affecting the left side of the ventricle, which is the aortic stenosis and mitral regurg, and also non-ischemic myopathies. I think possibly the most common one you come across these days is alcoholic cardiomyopathy really, maybe, I'm not sure, but possibly. Risk factors, you can see the top of the list is the Y chromosome. Again, we're on the losing side of the battle, like we always do. It's a major player in this condition. Previously mentioned hypertension, coronary artery disease, diabetes. Obviously, age is on the list of risk factors. The heart is like any other organ in the body, is designed with limited warranty, and it will come with time when it will start to fail, depend if other organs fail prior to the heart or the other way around. So none of our organs are built to be sustained forever. Let's quickly go through pathophysiology. And age is the main drive for all pathophysiological changes associated with heart failure. So to understand the principle of managing any medical condition, we need to have a good grasp of the pathophysiological changes. And as you age, the main player in the pathophysiology of heart failure, there are a number of principal physiological changes. These are listed below. So you can see human as they age, we progressively lose cardiac myocytes. This is usually associated with myocellular hypertrophy, cell slippage, and sarcomere growth. There will also be increase in interstitial fibrosis and cross-linking of collagen. Slowing of the rate at which the calcium is sequestered by the sarcoplasmic reticulum is another aging process, which is quite important for myocardial relaxation and diastology. So in order to understand this process, you need to be clear that diastology is not a passive process. It's not just opening a valve and filling the ventricular cavity with fluid. That process needs energy, and it's an active process to happen. So you can see all of this consumes energy, and cyclic AMP and sarcoplasmic reticulum is not simply passive dilatation. Stop me at any point if you want to ask questions. I think if you have, especially if you're going for the exam, if you have a bullet point of regurgitating this information in a structured way, it will help the examiner to show that you understand what you're talking about. So as a consequence of these pathophysiological changes, the heart will suffer from increased wall stress. There will be reduction in contractility, and with time there will be an increase in the chamber size, which is one of the major factors in heart failure. This, with the prolonged isovolumetric relaxation time, will increase the left ventricular end diastolic pressure. So you already, I've already mentioned that the calcium absorption in sarcoplasmic reticulum will be delayed with time, and that will cause a prolongation of your isovolumetric relaxation time. This, by default, will increase your left ventricular end diastolic pressure during both rest and exercise. And this is defined by left ventricular stiffness, which is one of the major features as well in heart failure. As a normal physiological response, the LV will try the diastolic filling to be more dependent of the atrial contraction. So, you know, in normal physiological humans, what's the rate of diastolic filling? I mean, how much the left atrium contribute to your diastolic filling? Rough figure, I mean, every person is different, but what do you think?
30%.
Yeah, about 15 to 30%, what they say in different physiology books, but I think in heart failure, especially if you start to develop AF, which is the natural rhythm after a certain age, that will be significantly more, maybe approaching 40, 50%. So in a nutshell, the principal problems are associated with aging, and failing heart are change in the shape associated with the chamber enlargement and ventricular wall thickness and stiffness. Okay, so all these basic physiological changes will cause these geometrical changes and trying to adaptation. Your body is smart, but not very smart. So what it's going to try and do is going to try and do this compensate for the reduction in cardiac output. So you get this neurohumoral response. The major system activated in this response is the sympathetic and the what is it called? The adrenaline, renin-aldosterone angiotensin. Yeah, I always get them the other way around. Angiotensin is the last one, isn't it? Oh, second one. Yes. Yes, I had to remember that for the exam and draw the whole thing. So there will be some modification to the endothelin receptors, nitrouritric peptide, and tumor necrosis factors receptors, which are quite recognized feature these days in patients with heart failure, and they will have some impact on the prognosis and mortality. So stimulation of the sympathetic nervous system causes peripheral vasoconstriction and retention of sodium and water by the kidney from both the sympathetic and the RRI systems. Yeah. So there is recent also evidence to suggest that the plasma norepinephrine levels in patients with heart failure is a predictive of mortality. Okay, so the higher this level, the higher this response, the more likely your mortality is. And that in a way tells you that this response, it's okay for the acute setting, whereas in the long-term running of heart failure prognosis is not beneficial. Does that make sense? So what we'll try and do is we'll try and maintain the blood pressure, and it'll try and keep the volume in the body to keep the blood pressure and the cardiac output. As with time, these activation reflexes will start to fail and they will have a detrimental effect. Okay. So the endpoint here is chamber enlargement, increased wall tension, increased myocardial oxygen consumption, which is completely opposite to what you want to happen, and reduce subendocardial perfusion. Okay, and reduce myocyte shortening. All these are bad factors. Reduce my subendocardial perfusion, part of it is because of the left ventricular hypertrophy, the left ventricular end diastolic pressure increase, and I'll come a little bit later when we talk about the balloon pump, about the coronary perfusion pressure, because I think to most of you here I've mentioned the equation of the coronary perfusion pressure, which is quite important to understand if you want to understand the cardiac perfusion cycle. So how are we going to diagnose it? What do you think, guys? You go to the ward and you have patient there. How would you going to diagnose it?
Shortness of breath.
COVID.
Ankle swelling.
Yeah, no, shortness of breath, ankle swelling, yeah. Yeah, JVP.
History of like nocturnal dyspnea.
Yeah, so all these features, which can, some of them be non-specific, but you'll see that combination of respiratory and cardiovascular. So shortness of breath, dyspnea, orthopnea, tachycardia. Tachycardia particularly quite important, atrial fibrillation. And most of these patients will have a decrease, unless it's something acute, like an acute MI, they will have a history of gradual decline in their exercise tolerance and their ability to climb, go uphill. They'll tell you, oh, I go uphill, I can't cope anymore with the dog or all that stuff. So it's a bit more of a gradual process, unless there is an acute pathology where they can present with pulmonary edema, acute pulmonary edema, cardiomegaly. In acute on chronic heart failure, you will obviously see as well features of the precipitating factor. So what are some of the causes of acute into chronic heart failure decompensation? What's the most common cause, actually?
Ischemia.
No. It's the most common cause.
Ischemia.
No. In acute on chronic. So someone with chronic heart failure, why would they decompensate suddenly? So arrhythmia. Okay. Which could be cardiac, it could be ischemic, but a lot of these people will have a non-treatable ischemia. And what I mean, like a lot of small vessel disease, already bypass disease, or myocardial fibrosis, which you can't treat. So arrhythmia is the most common cause for acute deterioration of chronic heart failure patient. But other things could be infection, PEs, all these stuff you can rule out, and you can look at the whole picture to identify them. The single most useful diagnostic test is obviously an echo, right? Yeah. So transesophageal echo in particularly is very helpful. Obviously not going to be able to do it on most patients, but transthoracic will give you a lot of information. Do you understand the difference between systolic and diastolic heart failure? So we'll talk about it. So when we talk about heart failure, and that's the other difficult bit, it's not always systolic. It's not always how much you pump, it's how much you fill the heart. So echo will be able to differentiate between systolic and diastolic heart failure, which sometimes on clinical investigation is not going to be obvious with signs and symptoms. The other thing that's important from the echo, it will determine the primary cause of heart failure. So things like, is it pericardial, myocardial, valve disease, all that stuff you'll be able to identify from an echo. Okay. Usually patient with an ejection fraction of 40% or less are systolic heart failure. Okay. Patient with normalish ejection fraction are usually diastolic heart failure. So to assess the left systolic ventricular function, we can do quantitative and qualitative assessment. So it's both. So quantitative assessment includes measurements of the dimensions, geometry, thickness, and regional motion of the right and left ventricles. Okay, it's very important to look at all these things. Comprehensive qualitative evaluation of the atria, pericardium, vascular structures is also very important. It's uncommon for these patients to have more of or one of the cardiac abnormality. So if they have heart failure, they can have other contributing conditions like regional wall motion abnormalities, valve disease. So it's very important to look at the quality of that studies. The quantitative measurements, the most common ones, which you might get asked about and you need to know, is ejection fraction, fractional area change, and fractional shortening. Okay, fractional area change and fractional shortening is a two-dimensional TOE, equivalent of ejection fraction. So it's obtained by measuring the left ventricular chamber cross-sectional area transgastric short axis view. So I'll show you a video instead of bluffing about some useless. This is what we call the fractional shortening, which can be a replacement for ejection fraction. I hope this will work. Well, I hope they can. Oh God, how many things is open?
Continue.
Continue. Agree. It's Matt's login anyway. Okay, so I don't know people who knows Echo, but this is Phi's view. So this is, oh God, this is very quick. You can see all these videos on YouTube actually. So this is the parasternal long axis view, which is a basic Phi's window. I think most of the intensive care trainees will, by the end of their training, should be able to achieve this. So what you do is, if you don't get a very good window, you can use an M mode, because M mode will pick the definition of the wall much better than your eye if you have a lot of other artifacts. So once you activate the M mode, you'll see that change in the black area, the distance between the two bits here, which is during diastology, and the two bits here during systology. So that what we call the fractional shortening, which in a way it's quite relatively good predictor of ejection fraction, bearing in mind you don't have regional wall motion abnormalities. So in patients without a significant drop in one of the regional walls, you can use that to estimate your ejection fraction. You see that? I think this is a default on their machine that drops the ejection fraction. We don't have it in ours, but it doesn't matter. Okay, so any questions about the ventricular systolic function assessment? No? Easy, yeah? All of you know what ejection fraction is. Normal should be 55 plus. Anything below 40 is systolic. Above 40, it's a bit grey. Normalish, it's not systolic, definitely. So the diastolic assessment is slightly more complex. And what we need to do is, first, we need to identify if there is a diastolic dysfunction. And second, we need to grade the diastolic dysfunction. I think if you get an exam question, it's more likely to be related to diastolic rather than systolic, because it comes in the BGA and the continuous education on regular basis. Okay, and there is two articles, one in 2009, one in 2016, which you need to have a look at. So this is what we called the joint statement by the American Society of Echocardiography and the EICVI, European Association of Cardiovascular Interventionists, something like that, or imaging, okay? So they identify 4 different variables needed to determine diastolic dysfunction. As you can see, the variables are all there. They need to identify the average E over E prime. I'll show you what these different variables are. And you need to identify the septal E prime velocity, the tricuspid regurg velocity, and the left atrium volume index. In order to understand what all these are, you need to understand how the pathophysiology of diastolic dysfunction develop, which we'll go through in the next couple of slides. If you have more than 2 variables, it's easy. It's definitely diastolic dysfunction. If you have less than 2, i.e. 0 or 1, you mean you don't have diastolic dysfunction. When you have 2, then it becomes more complicated. I don't know why they made it so challenging. I'd say like 2 or more, just say diastolic, honestly. So you have to do some more measurements like pulmonary vein flows and a few other things. And you have to become a bit more expert in kind of assessing diastolic dysfunction. So once we define diastolic dysfunction, I don't think this is a very easy flow chart, but we need to quantify the severity. And that's why I put the chart there, because it's part of the guidelines. Because it is important, actually. It's not just, okay, why does it matter? It does matter. It has implication on prognosis and treatment. So certain treatments you wouldn't give to certain types of diastolic dysfunction. Actually, 0 and 1, you don't give any treatment. 3 and 4 is when it become complicated and challenging. It will have significant impact on mortality. Do you want a couple more videos? Yeah? Okay, let's show you. This is how to measure the transmitral flow velocity and the E prime. Okay. So you put the cursor at the mitral valve inflow, and then you put the Doppler waveform, and you'll get this, what we call it EA wave, mitral inflow. If you have atrial fibrillation, you won't have the A, because the A is basically your atrial contractility. And then finally, to get the septal E prime, is you use what we call the Doppler, tissue wave Doppler. This is what we call tissue wave Doppler. So the cursor will be here on the septal, that one if you see the green bit. And once you put tissue wave Doppler, it will measure the velocity of the acceleration of the ventricular wall. You can do it septally and you can do it laterally. Septally is enough if you have a normal left ventricular function in terms of no regional wall motion abnormalities. If there is a significantly difference between the septal and the lateral, then you have to measure both and take the average. So just bear in mind, these are velocities. These are not measurement of change in geometry or physiology. So let's go back to the presentation. So once you have all these measurements, you can decide what grade of diastolic dysfunction is. And I've already mentioned there are 4 grades, from grade 0, which is normal. Grade 1 is what we call impaired relaxation. Grade 2 is pseudonormalization, and grade 4 is restrictive. 3 and 4 are significant and have quite important implications, as I said, to management and prognosis. So if you think in a normal heart, the E and the A represent the left ventricular filling. And we already said that the majority of the left ventricle filling happens before the atrial contractility. Does that make sense? And therefore, you see, like the E to A ratio is about 80%, which we already mentioned that the contribution of the atrial contractility is about 15–20%, 30%. And therefore, this is a normal ratio. So the E should be higher and bigger than the A. When you start to have diastolic dysfunction and heart failure, we said the left ventricular stiffness will start to develop. It won't relax as normal because relaxation is an active process and consumes cyclic AMP and all that stuff and add energy. So there will be a decrease in the compliance of the left ventricle. But what happened here is the atrium hasn't built the reserve to improve that, because we said the left atrium with time will increase contractility and contribute more, so it will improve the filling. So what you can see here, you can see that the A is bigger than the E. And in this situation, it's very clear, because if you have A bigger than E, this is abnormal. This can only be grade 1, because all the others, you can see the E to A ratio is more than 1. Yeah. With time, as the left atrium left atrium start to get bigger and contract more and contribute more, the increase in the left atrial pressure, we think about a gradient now. So the left atrial pressure was 5, this was 20. The left atrial pressure now is 15, this is still 20. The gradient will be bigger, isn't it, when the valve opened? Because the left atrial got bigger and got more hypertrophic, and therefore E will start to go up again. And that's what we call pseudonormalization. Finally, when the left ventricle is so hypertrophic and so stiff, there will be a very quick acceleration, because once the acceleration happens, it will fill very quickly and stop. And that's when you're going to have the grade 3, which you have to have an E to A ratio of more than 2. If it's less than 2, it's not grade 3. I don't think they will ask you in that much detail, but it's useful to understand this, because this in a way is a reflection of the physiology of the diastolic dysfunction. Yeah, so now you know what happened with diastolic dysfunction. It's not something that happened grade 0, 1, 2, 3, 4. It's a continuum. So some people, you see them in grade 1, you echo them maybe 2 days later, or actually if you give them diuretics and you echo them later, it might be normal. Yeah. So this is a continuous process. How are we going to manage it? How are we going to manage heart failure? Oh, sorry, any questions about diastolic dysfunction? Did I make it too complicated? Yeah? Okay, good. How are we going to manage heart failure? Can you find a cure? No. You'll be very rich doctor. Honestly, there is no cure for heart failure. Much can be done to improve physical activity actually these days, and keep patients more comfortable, improve quality of life. American College of Cardiology, American Heart Association have described 4 stages of heart failure. I think they're jealous from the New York Heart Association, because they made it A to D instead of 1, 2, 3, 4. Do you know that? Yeah. So the American college made a classification of 1 to 4. But there's very few treatment that can cure. There's no cure, obviously, just improve quality of life. Mortality is worse, as we already said. These are the 4 grades, or 4 stages, wherever you want to describe them, A to D. Are they much different from NYHA 1 to 4? Not really, very close, but what you would say for us as intensivist or anesthetist, grade A and B is of a very little significance. Grade C and D is the one that we concerned about and we worry about. So grade A is pretty much patient at a high risk of developing heart failure, but they don't have any symptoms or identified heart failure condition as such. So potentially they have a normal echo, they don't suffer with any shortness of breath, they will have systemic hypertension, diabetes, or coronary artery disease. Type, oh God, seriously, honestly. Type B is, who develop structural heart disease strongly associated with the development of heart failure, but who never had signs or symptoms again. So these are guys who would have an echo that potentially suggested that in the near future they will go to stage C or D. I'm not going to go through stage C and D, you can pull the guidance, but basically stage C is someone who's living at home with stable chronic heart failure. Stage D is pretty much palliative kind of heart failure. Let me put this on silent, sorry. So therapy, the therapy will be focusing on 3 different aspects. So treat the underlying cause, remove contributing factor that can worsen heart failure, and treat the heart failure itself. So what are the anesthetic and intensive care implications for stage C heart failure? 2 things we need to worry about. They're already there on the monitor. Myocardial depression and peripheral vasodilatation, okay? So if the patient presents for surgery, that's unrelated to heart failure, the 2 principal cardiovascular events to control is your myocardial depression and peripheral vasodilation. Any change in either of these should be minimized, because these are patients who are living on the edge. Yeah, they're very fine-tuned, so you need to be careful. Historically, people use drugs like etomidate and ketamine. I don't use ketamine for these patients, really. I can't remember the last time I used etomidate. I do use it, but I don't see the need for it. I don't know if you've been with me in theatre. My anesthetic is pretty much a big dose of fentanyl and a big dose of midazolam, which pretty much it's quite stable. I wouldn't recommend ketamine though, personally, in someone with heart failure or someone with coronary artery disease. Why is that?
It can increase circulating catecholamines, and so it can increase the amount of myocardial oxygen demand. Yeah,
actually, in a way, it's a little bit detrimental to your cardiac oxygen consumption compared to supply, because the other problem with it can potentially cause a relative significant tachycardia, which can worsen your diastolic time and coronary perfusion. So majority of patients with impaired LV function, we already said, are dependent on their preload to main ventricular filling, and they will rely on increased sympathetic drive to maintain the blood pressure and cardiac output. So therefore, you have to be quite fine-tuned balance. Sometimes, I don't know, maybe I give them a 1 or 2 mils of phenol with the induction if it's a very severe heart failure, and use minimum doses really. But in my experience, a big dose of opiates and benzos is quite safe. Depends if you can extubate, if you need to extubate the patient at the end of the list or not, which is very different here. Inhalational agents, they reduce myocardial contractility in a dose-dependent manner. We know that, pretty much all of them. But the effect is slightly different between different agents. Isoflurane is popular among us in cardiac, I think. I don't know, most people would use it. I don't think SIVO is worse or better. So if you want to use SIVO, use SIVO. There was some evidence, and that's still conflicting, about the impact of the inhalational anesthetic agents on cardiac remodeling and ischemic remodeling time and all that stuff. The most recent evidence, which came about 4 or 5 years ago, I can't recall the name of the paper. There isn't evidence of inhalational versus intravenous. So I think the majority of cardiac anesthesiologists will use a mixture of propofol plus inhalational agents in theatre. So that's my current practice at the moment. If you're gonna look at different causes of heart failure, one of the important ones is cardiomyopathy, okay? Because here you need to understand there's different types of cardiomyopathies leading to heart failure, and the management for different ones. And when I'm talking about the management, I talk about the hemodynamic management during acute illness or anesthesia is different. So if you're talking about, so it's like dilated, restrictive, and hypertrophic cardiomyopathy. If we talk about restrictive cardiomyopathy, it's a quite severe and difficult to manage. It's very challenging. So what happened with these patients, they will be very difficult to fill. If you vasodilate them, the preload will struggle. The other problem with them is if you paralyze them and go into positive pressure ventilation, the RV could be quite interdependent on the LV, and the increased intrathoracic pressure with the reduction in the preload, they can arrest. So restrictive cardiomyopathies, I would encourage you to make sure they're full, keep systemic vascular resistance. If you can anesthetize them spontaneously breathing, it's advantageous. If you can't, then you have to take all the monitoring and precautions and maybe ask people with experience. For dilated cardiomyopathy, it's a little bit easier in my practice and opinion, as long as you don't make them struggle with hypotension, because then the coronary perfusion pressure will struggle. For hypertrophic cardiomyopathy, you have to be aware of SAM. Do you know what SAM?
Systolic anti-mitral leaflet
Motion, yeah. So it's a sound physiology. These will have a very thick ventricles, and if you actually give them inotropy, what will happen, the anterior leaflet of the mitral valve will squeeze into the left ventricular output and will actually worsen the cardiac output. The other problem with these, if you increase the inotropy without taking other precautions, the coronary perfusion pressure will struggle because the muscle will work harder with less blood supply. So again, make them full, control the heart rate. Very important to control the heart rate. Don't let them go into AF and don't let them go very quick, because the worse the left ventricular hypertrophy, the more they're dependent on the atrial kick for their preload. Yeah? Easy? You can manage them now? So for grade D, there is heart failure treatment. I'm not talking here about an aesthetic implication. I'm more talking about intervention that you might need to introduce to help them for certain cases, because very rarely these patients will present for anesthesia, pretty much maybe palliative or directly related to the heart failure treatment itself. So here we can talk about pharmacological intervention and non-pharmacological. Pharmacological is mainly talking about inotropy really, and things that are used to reduce the preload. So inotropy, you all know there's majority of it is catecholamine agonist, and sometimes we use phosphodiesterase inhibitors. Yeah. Levosimendan is not very clear yet, because a lot of people think it's direct calcium sensitizer. There is an evidence coming that it potentially could be a phosphodiesterase inhibitor as providing its mechanism rather than a calcium channel sensitizer. Which one is better? Or the outcome, if you believe studies? Not really very clear evidence, but they think dopamine will have a better outcome even than the balloon pump in myocardial stunning. Once you use phosphodiesterase inhibitors, the outcome hasn't been shown to be improved, and a lot of people will struggle with significant hypertension, which can be quite challenging to manage. I'm talking here about pure LV dysfunction. I'm not talking about RV dysfunction. Okay? So non-pharmacological interventions are synchronized pacing, surgical ventricular restoration, which is really very, very, very uncommon. I've seen maybe one or two, I don't know. And mechanical support. Okay, so surgical ventricular restoration is what we mean by, like, some people when they have a massive anterior myocardial infarct, there will be a big part of the left ventricle which can be fibrotic and can contribute very little. So they kind of dissect that and rebuild the left ventricular cavity to make it more geometrical acceptable and reduce the impact of the heart failure. Synchronized pacing is far more common. So dual chamber pacing and ICDs are common, and they're based on good evidence. These here are different studies and trials on dual chamber pacing. Have you all seen dual chamber pacing on our patients by now, I hope, yeah? Yeah. So sudden cardiac death due to arrhythmia is a very common problem in patients with heart failure, so they should be treated aggressively and try and control them in sinus rhythm, okay? It is crucial. We already said about the atrial synchronization for systole, or atrial systole for ventricular filling, which is quite important. All these trials shown evidence in terms of improved mortality, improved ejection fraction, improved quality of life, improved mitral regurg in all patients with heart failure. So dual chamber pacing is not by putting a pacing wires into both ventricles. It's, do you know how that works? It's still transvenous. So when I say transvenous, it's going through the venous system into both atria, so pacing both atria, and then a third wire going into the right atrium, into the coronary sinus, and through the venous drainage of the left ventricle, pacing the left ventricle. Some of the old, what they called early dual chamber, were pacing through the right ventricular apex. That had actually detrimental effect on a lot of patients, because the way the contractility of the right ventricle affects and impairs the left ventricular filling at the same time. Okay. What I was going to say about the dual chamber, one more thing. They improve actually ejection fraction by 15–20%, at least in these patients from the baseline. So they can have a significant impact. I was going to say something else. Anyway, forgot. Okay. Any questions about dual chamber pacing? ICDs, they can save lives. I think most ICDs are dual chamber paces these days anyway. Oh, that's what I was going to say, sorry. Dual chamber pacing is needed in the majority of heart failure, but not all of them. So dual chamber pacing need to be assessed by an expert cardiologist, because they need to have an interventricular desynchrony. So you can't put it to all patients with heart failure. If they, for example, they have a normal AV conduction and normal QRS complex, there won't be an indication for dual chamber pacing, so they need to have a prolonged AV conduction, normally left bundle branch block. I think what most cardiologists will go for is an AV time of more than 200 milliseconds plus, yeah? And then I think finally is mechanical assistant, intra-aortic balloon pumps and LVADs. We don't do LVADs here, we do a lot of intra-aortic balloon pumps. Mechanical assist device are designed to decrease the mechanical work of the heart, so they improve the coronary perfusion pressure. They're okay to use. I think the main challenge is to assess how much potential the patient's heart function together with the resultant multi-organ failure is reversible. So the problem is, for me, is not how to use it or when to use it, is to assess if putting an intra-aortic balloon pump is going to buy me time for that body, heart, kidney, blah, 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 to recover and go home. And that's really the challenging bit, because it's very hard to assess how much of the LV function will recover. If you have an obvious and reversible event, which, for example, an out-of-hospital cardiac arrest, LAD disease, which you opened, and myocardial stunning, you're kind of a bit more, optimistic about it. In chronic heart failure, I think it's pretty much useless. So the primary goal of the balloon pump is a technology that used as a comparator. So pretty much as a PA catheter, it can be called as a gold standard. It isn't really, but I think it's the most commonly used assisted device. So all the others are compared to it. It maintains your cardiac output. It's effective. It's been shown to be effective for intractable angina, MI, mainly STEMI, improved outcome. For perioperative use, the evidence is very difficult, but most of the evidence to support use of intra-aortic balloon pump perioperatively in cardiac surgery is when it's induced preoperatively, at least for 2 hours. Do we do that here? Not really. Why? So the evidence for it when coming off pump is very little, of null almost. Why don't we put it preoperatively? The evidence might be there, but again, it's associated with risks and complications. So the complications of limb ischemia, organ death, all that stuff is about 3 to 5%. If you have someone who's coming for heart surgery of 2 or 3%, can you argue putting an invasive procedure pre-op with a mortality of 3 to 5%? Maybe not really. So that's what I'm saying. When you look at the evidence, you have to be careful how you interpret it. You have to put the evidence for that specific patient, not just go and apply it randomly. How does it work? This diagram is what you would normally see on the aortic balloon pump monitor, if you seen one of them. So you can see the diastolic time here, dichrotic notch, where your normal diastolic time starts, and this is when you're going to have your coronary perfusion. If you have an intra-aortic balloon pump, you see all that area under the curve. All that is pretty much improving your coronary perfusion during diastole and improving the cardiac output. At the same time, for the next cardiac cycle, when it deflates, it creates a vacuum. So your afterloads will reduce, your peak systolic pressure might drop, but your cardiac output in terms of volume will be improved. This, as a consequence, will have an effect of offloading because of its effect on the preload for the next cardiac cycle. And that's why cardiologists use it for heart failure, pulmonary edema, all that stuff. I think I'll stop here, unless you have any questions, guys. These are the references, actually, which I would recommend you read. Most of the stuff in this presentation are from these 5 papers. The 2 diastolic dysfunction papers I think you need to be aware of if you're going for your exams. The 2 guidelines are massive, but there's a lot of tables and easy to read, some of it, so go through it quickly, and then you can read through the principles of intra-aortic balloon pump, and there's a publication in 2009. Okay.
Thanks very much.
No, thank you. You can email me if you have any questions or queries. I hope I didn't give you a massive headache after this presentation.
I said about maintaining rhythms really important, because we quite often have septic patients at the Royal who might be post-op, for example, with bowel injury that are okay, and then they go into AF and fall in a massive heap, and you can shoot up on their NORAD without a huge amount being achieved, really.
And maintaining rhythm is very important, and that's why I said, in particularly in certain types of cardiomyopathies, but for all types of heart failure, you have to sustain sinus rhythm. And in Glenfield, we have the leisure of the ability to do TOE once we need it. So I would suggest, if you have a patient with significant cardiomyopathy and heart failure, and he goes into AF, TOE and cardioversion, to make sure he hasn't got any clot in his atrial appendage. It's a very good treatment, especially if they're anaesthetized, obviously, in theatre or on the intensive care unit.
Yeah.
You
TOE
can use,
is usually a challenge at the Royal.
yeah, well, that's the thing. With the transthoracic, you can't rule out a left atrial appendage clot. And to cardiovert them, obviously, you have to balance the risk and the benefit. But if you have the ability to access a TOE, that would be better. The other thing is the drugs that you can use is amiodarone is the drug of preference for most of these arrhythmias. DIG is coming as a equivocal, but to be honest, we do use it sometimes. Beta blockers, obviously, is a chronic treatment for these conditions. When they're acutely decompensated, it might not be very helpful when you have increased inotropic requirements. But sometimes we use short-acting beta blockers like esmolol.
Yeah.
And just give it and run away from the bed, make the nurse struggle. No, don't do that.
Yeah, just don't look at the blood pressure for a bit, and then it will slow down.
Yeah, absolutely. Phenol is good one. Phenylephrine, 2 or 3 mils. It slows your heart rate and give you blood pressure. It's not sustainable.
It's a flush, isn't it? You use it as instead of a saline flush.
Yeah, but it's not sustainable. Any other questions?
Thank you.
Thank you very much. Good to see you, Zoe.
Thanks. Thank you, Sam.